Yeah, so the treatment of insomnia is quite clear cut, really. It's actually very heavily evidence based, and particularly within the framework of CBT. And we call it CBTI, so Cognitive Behavioural Therapy for Insomnia. And it's it's universally accepted as to be the gold standard for treating insomnia. It's at least as good as medication, in fact, better longer term. So there's unequivocal evidence there. And however, it's easy to do, like it's easy to understand. It's easy for not only psychologists to administer, but there's many studies where nurses, other sort of therapists can lead the CBTI. Having said that, it's really difficult for the client to adhere to. So simple things, simple strategies, but not easy to do, particularly when you're already debilitated and you're really suffering with a great deal of fatigue and low energy and sometimes low mood and other comorbidities, which we talk about later. So the essence of CBTI, in a way, within the sleep field, it should be called maybe BCT, because we do the behavioural first. It's really important to do the behavioural first. And the two hallmarks, the hallmarks of the behavioural side of it at least, these two notions. One's called sleep restriction, it used to be called bed restriction. And it's also known as sleep consolidation. I prefer to call it that, but many textbooks still call it either bed restriction or sleep restriction. Let's call it sleep consolidation, more positive term. And also is the notion of stimulus control. So they're the two behavioural things, and I'll talk about those now. And then I'll talk about what the cognitive components are and what we do in treatment. So in terms of sleep consolidation, it's really important to get the client or patient, whatever you like to call them, to match their time in bed with the amount of sleep that they're realistically going to get. So they know that if they haven't slept for 8 hours for many decades or many months, don't aim for 8 hours that night. If their sleep diary or their self-report reflects that they've only been getting 4 or 5 or 6, then get them, the sleep consolidation principles would say, get them in bed to match that. So pick out a window based on collaboration, based on their sleep diary. Look at their opportunity for sleep being maybe, if they're only getting 5 hours, I would have them in bed for no more than 6. So try to maybe throw in half an hour for goodwill to, getting sleep initiated and having maybe a couple of wake-ups in the night. But so depending on a really common window for sleep that's prescribed, even in the first session, like the end of the first session, it's nice for the client to come away with a bit of a plan. If you've got the information about their sleep, the sleep diary, you need to get them in bed for roughly, say, between midnight and 6 is a common one. But if they say to you, I'm never going to get up at 6, forget it, make it a bit like, be lenient, make it 12 till 7, 12 till 6:30, make it realistic for the client. But that's the aim, is to match the time in bed, not wasting time. People get into bed early. This is a really typical thing in the first session. They'll tell someone like me, getting to bed at 10 because I want to maximise my opportunity for sleep. And then they're in bed till about 7. So they're in bed for that's 9 hours, and they're getting about 5. So they're just passing, they're not getting a high distinction. We want them to get 85% sleep efficiency, which would be looking at a simple formula of their total sleep time divided by their time in bed in terms of hours or minutes. So in that scenario of someone, that one I just said, their total, the fraction, if you like, was say 5 out of 9, and that's we work out the sleep efficiency based on that. You want them and you encourage them to get a high distinction, and usually people with insomnia are real high performers, perfectionistic, self-starters, high-flying type people, and so they're happy to have that scenario of getting a high distinction. So you get them into bed, say 5, or you want them to get 5 out of 6 or 5.5 out of 6, and it's not realistic to expect to get 6 out of 6. So that's sleep consolidation, also known as bed restriction, sleep restriction in the literature. Stimulus control is a really important strategy as well. It's very important to highlight this the very first session, that they have a very clear association. You can talk to them about classical conditioning and Pavlovian principles, that they associate getting into bed with sleeping. That in their mind, that's what they do. They get into bed and they sleep. It's not where they put their iPhone on and their laptop and their TV and their books and or their worry, or they're fighting with their partner, all those sorts of things. It's not. You go into bed when you're ready for sleep. So a simple formula of bed equals sleep. So getting rid of all the other stimuli that are incompatible with sleeping. So stimulus control is very easy. They know that. They might not have known it's called stimulus control, but they've known that. They've read it on the net. Someone's told them before not to do those things. So that's a really important. You've got to make sure that your stimulus control principle and your sleep consolidation is sorted out in the very first session even. And then we also, the other components of CBTI are things like sleep hygiene. Like we've talked about, and you've already talked to them about that, but you make sure that their sleep hygiene is A1, that they are doing all the right things, and you've eliminated potential really high-risk things like caffeine or other stimulants. You also make sure that they are getting appropriate bright light, that you have a bit of an assessment with their circadian rhythm in the absence of the fantastic, like you don't have access to melatonin assays or blood tests, and psychologists, particularly working in isolation, aren't going to be able to do that. But we need to have an understanding of them, their circadian rhythm. Where are they particularly late with their rhythm? Are they advanced? Where do they fit along in the 24-hour day? It's important to recognize, for them to get an understanding that really, really basically, that melatonin is secreted when it's dark, and our body secretes its own. You don't have to take the pill, the little exogenous melatonin. We all secrete our own. If they know that everyone can understand that melatonin is secreted in darkness when the eyes get the message, and they also can really, really easily understand that melatonin is suppressed by bright light. So in the morning when they wake up, and at the moment, depending on where it is, where you are in Australia, where you are in the world, it's different times of day when it's sunlight at the moment. If they wake up and it's 7, they need to get bright light in their eyes straight away. It'd be really important to have access to light. It's a very complex thing that we won't go into right now about light and timing of it. But if the client, it's part of CBTI is for them to understand the basic principles of having a healthy circadian rhythm, that making sure that they get light to suppress melatonin. We don't want melatonin in our system during the day. We only want it at night. We only want it to help promote sleep, and not so much even promoting sleep. The main thing is it's a synchronizer for our body clock. They just sort of anchor us to the 24-hour day. So they're the sort of elements. It's really important to introduce some kind of relaxation technique. Someone needs to have some sort of relaxation, and the literature doesn't really discriminate whether it's a breathing technique, a sort of a visual imagery type thing, or a progressive muscle relaxation is another. They're sort of the 3 most common types of relaxation. So as long as it's something along those lines, and whatever the client and the practitioner decide works best for them, to really give a bit of training to relaxation, to make sure they've got some kind of skill in something like that. Adjuncts to treatment can be things like mindfulness, etc. And there's more and more evidence linking mindfulness plus CBTI, which is interesting, as an adjunct, like they sort of support each other, rather than just CBTI on its own or mindfulness on its own. The combination's really is useful. Speaking of all those sorts of behavioural things, we've come to the cognitive side of CBT. And the cognitive side of CBT are the things we address usually after we've happily looked at the behavioural side. Then maybe had a couple of sessions before you even start talking much about the C part of it. Having said that, in the very first session, you might have made a note of potential cognitive distortions. And what I mean by that is people might say, oh, it's all because if only I got 8 hours sleep, I'm fine, or if only I sleep by midnight. If I get to sleep by midnight, then I'm fine. Or people might say if I'm not asleep by 2, that's it, I'm gone the rest of the night. They have these quite clear cognitive distortions, like preconceived ideas that are not actually fact, but it's within them they think they're fact. They really truly believe these things, and often we meet our expectations. If what we're telling ourselves, then we perform to that. So if they think they're not going to sleep because it's 2 o'clock, in the morning. And then what might happen is then they've got so much arousal and stress around that. Lo and behold, that interferes with the sleep, and then they don't sleep. And then they think it's because of that. And so they have it sort of cements it, and they sort of have these quite firmly entrenched beliefs. So you can talk to them about, sometimes it's quite obvious what their beliefs are. There's also another tool that helps with the cognitive side of it, and it's called the Dysfunctional Beliefs About Sleep Scale, the DBAS. I wouldn't be talking to them saying it's called the DBAS. It's not a really useful term to call it dysfunctional beliefs. Sometimes it's nice, as a psychologist talking to clients, it's nice to say it's unhelpful beliefs, or things that are really, they're not helping you. They're actually holding you back. You're sort of stuck in a vicious cycle, and it's perpetuating it. It's perpetuating something that might have otherwise gone away if you didn't have the firmly held beliefs. So the cognitive side of it is, first of all, to assess if there are any cognitive distortions. And then, with whatever measures you have, like with your particular style, within CBT, traditional CBT, people are taught, cognitive challenging, cognitive restructuring. There's different techniques that you can address those cognitions. Some people, like me more recently, I like to use mindfulness-based principles to address the cognitions. I might use it in a more gentle way in that sense. And there's more research around that at the moment, more and more evidence to suggest that's an okay way of doing it as well. It's effective way to address someone's cognitions. To use, to perhaps to challenge maybe that if the thought is, oh, it's a disaster, or it's 3 o'clock, I've looked, it's a disaster, I'm never going to get to sleep, it's all doom and gloom, I'm going to lose my job, but there's this cascade of cognitive beliefs. A mindfulness-based approach would be to use more acceptance around, okay, it's 3 o'clock in the morning, I'm awake. Does in itself is not a disaster, because natural sleep it involves lots of there's wake-ups all the time, like all of us would wake throughout the night. But mostly we're not aware of it. Mostly it's so insignificant and for such a short period of time, not salient, doesn't sort of strike a chord with us, that we don't get distressed by it and we just go back to sleep. But once we're distressed by being awake and we think it's a bad thing, it will become a perpetuating problem.